Hi, good afternoon, everybody. I congratulate you for staying right the way through. You're probably desperate for some nutrition yourself, but I'll try and be quick because we are running slightly behind time. So, as I say, I'm Rachel, currently leading on prehabilitation and enhanced recovery. I work in Cardiff and also in Swansea. So, without further ado, this is the Marathon des Sables. Individuals compete over 5 days, 5 back-to-back multi-marathons. Grueling temperatures, burning about 25,000 calories. When competitors are interviewed, they say peak physical, mental stamina, psychological preparation, training, obviously fitness training, and nutrition. This is the marathon that we're all here to talk about today. It's been a great day. But, this is the marathon de table, I should say. Okay, but this marathon doesn't just happen 5 days. The journey for a patient can go on, I'm talking specifically around cancer for this session, I should say, continues for weeks with a treatment plan, chemotherapy, radiotherapy, and if not, years for some patients. Whenever I speak to anaesthetists, I love it because many of you have done, Ironmans, triathlons, back-to-back marathons. You've probably done the Marathon des Sables yourself. But essentially, you've just got to pick up any exercise magazine, and on the front cover, you will see nutrition, nutrition, nutrition. So how many of you think about nutrition in your day-to-day practice? You don't have to show of hands, it's a rhetorical question. But essentially, we don't use the analogy between the two. I think we pay lip service to it, but I think it's really important that we try and move this on to the forefront. As I've already said, many patients undergo neoadjuvant treatment, surgery, and then adjuvant treatment. And you can see, specifically, there's gaps in between each of those areas, often organisational gaps. And the patient often falls between the two, increasingly deteriorating in nutritional status, frailty, and becoming more fatigued, muscle wasting, and sarcopenic. What we want to do is try and join up services, work across organisations, work across barriers. And this is where prehabilitation and optimisation comes in. 40% of patients is an old study now, but sadly the incidence is still reported to be approximately the same. 40% of hospital patients on admission are malnourished. In our cancer population, over 70% of our patients are coming into our hospitals malnourished from the community. What's concerning, after a week in hospital, the incidence of malnutrition increases. So we are not helping the situation. I'm not going to go through any detail, but essentially there's multiple reasons for malnutrition, ranging from reduced food intake when food is available, such as anorexia and difficulty chewing and swallowing, to reduced food intake when food isn't available, so patient choice as well. But also with surgery, we've obviously got an increased demand, increased nutritional requirements. But what is most concerning is the fact that malnutrition can actually be caused and precipitated by lack of recognition and attention to nutritional intervention. And we've all got a responsibility for that. Again, I'm very lucky I speak to and teach medical students about nutrition. And if I say one thing, if you take nothing away from my session, which I hope they do, but if they don't, nutrition is inherent in all life processes. And I think sometimes we don't actually understand what we're talking about when we talk about nutrition. Every cellular activity, every enzyme, every cofactor. As a result, with malnutrition, every organ and system in the body is affected. Coupled with surgical response to surgery, often clearly you have massive retention of salt and fluid, loss of muscle mass, and depletion of potassium, magnesium, and other electrolytes. On this diagram, I'm basically trying to show you the different stages of how a patient would present. So essentially, you've got potentially increasing nutritional status when the patient presents with an illness, and then you have the multiple hits over time. And then we expect our patients to recover when they're most vulnerable. They have the most poor nutritional status. There's a plethora of varying quality studies around nutrition in the perioperative setting. But essentially, malnourished patients in the perioperative setting do worse. They have more complications, they stay in hospital longer, and they have an increased chance of dying within 30 days. And there's also now a link with, obviously, long-term survival. There's also associated prolonged cost, increased cost associated with perioperative malnutrition. Weight loss and sarcopenia have been linked to reduced survival. 8 months survival for a sarcopenic patient with colorectal cancer, as opposed to 28 months with a patient without sarcopenia. However, there's good news. I really enjoyed Raman's session this morning about risk assessment. Well, nutrition should be an integral part of that risk assessment. Nutrition is a modifiable surgical risk factor. And this is where prehabilitation comes in. So the aims of nutrition optimization and prehabilitation should be focusing on multiple things. One, about improving access to potentially curative intent surgery. Reduce the likelihood of complications, reduce time dependency in hospital, improve quality of life as well, and long-term survival. What we're trying to develop in South Wales is a seamless, integrated perioperative pathway starting in primary care with primary care optimization. We are in advanced discussions with our primary care teams across areas to look at how we incorporate optimization within primary care. Coupled with that, we're now on the cusp of widespread implementation of our community-based prehabilitation, and obviously carrying that good nutritional care throughout the patient's care trajectory, and obviously leading into recovery and rehabilitation. So the first step then is nutrition risk assessment. It is not just a case of albumin. Absolutely not. And this slide reflects that. So this is a patient who is anorexic. She's got anorexia nervosa, and she's got a BMI of 14. What's her albumin? 42. Because she's not in an acute phase response. This lady, post-op, peripherally muscle-wasted, albumin is 16. I'm not saying she's not malnourished. Okay, I'm saying it's not the be-all and end-all of nutritional assessment. Nutritional assessment should include A, B, C, D, and E. A being anthropometry, B being biochemistry, C being clinical, D being dietary, and then you evaluate the interventions that you've done. It's not a case for a one-off intervention. This should be a continuum. For the period of time, I'm not going to go into any detail, but essentially, I think the colleague just said earlier, in 10 years' time, hopefully in 5 years' time, we will be talking about sophisticated interpretation of muscle, and in terms of muscle composition, in terms of fat infiltration and muscle quality. This is correlating in exciting studies with, obviously, survival, perioperative complications. Obese patients, for example, with low muscle mass had increased mortality and morbidity at 30 days. Now, once when I was working as a clinical dietitian, one of the surgeons came up to me and said of an obese patient, it's okay, they can live off their fat. Don't worry about it. Well, clearly, if they're with a physiological understanding, then they will be degrading muscle. Okay, so it's not enough for your patients to come in who are obese to live off their fat. Similarly, nutritional prehab is not just about giving infusions, it's not just about giving carbohydrate loading, and it's not just about giving boxes of drinks. This is a process, and it should start as soon as the patient enters the healthcare system. And normally, good nutrition optimization can take about 2 to 4 weeks as a minimum. Clearly, that's dependent on the patient's nutritional status entering into the organisation. Nutritional prehab promotes anabolism. That is the aim of prehabilitation. That is what we're trying to achieve. Now, the current literature on prehabilitation is very exercise heavy. Clearly, I'm a dietitian by background, so I'm waving the flag for nutrition optimization. And that's not for me to promote nutrition because I just think it's a good, it's going to get more dietitians. That's actually because fundamentally it makes sense. Exercise without adequate nutrition in an already malnourished patient can actually cause harm because you're increasing the energy expenditure without compensating for nutrition. Exercise with or without nutrition, there's a lot of work at the moment around types of proteins to give, whether you give whey protein, branched chain amino acids. It's really complex. But essentially, what is important is a targeted nutrition assessment, and nutritional prehabilitation can really improve patient outcomes. A study of nearly 2,000 older adults indicated that our patients just are not, the general population are just not consuming enough protein. Half of this study adults were having less than 1 gram of protein per kilo per day. We should be aiming for a minimum of 1.2 to 1.6 grams of protein per day. Certainly I find that quite hard, and I'm a healthy adult. Again, there's a lot of work coming out of Franco Carli's group in Canada about nutritional prehabilitation in terms of whey protein supplementation, and it combined with an exercise program. And essentially, the results look really promising with a 2-day reduction in length of stay. A lot of what I've talked about has been about before surgery, prehabilitation. But essentially, the work that was presented this morning through the report around DREAM is really exciting. 25 years ago, when I started as a dietitian, patients were starved for about 10 days after major surgery. To sit here on the same stage with somebody saying about DREAM increasing is really, really exciting. And the reason for that is because it's independently correlated with survival. The ability to eat and drink on day 1 after surgery has also not just surgical-related survival, but also cancer-related survival. I'm going to flick through some slides. So when your juniors are on the ward and they see a patient who's going to be discharged from home, and the patient says, "Oh, I'm doing really well, doctor. My appetite's it's not great, but I'm eating really well." They're having half a bowl of porridge and a cup of tea, soup, half a slice of bread and butter, 5 spoons of custard and a cup of tea, and some soup and ice cream. And the junior doctor writes in the notes, "Patient's doing really well," and the patient then goes on their merry way. But actually, is that patient doing well nutritionally? If they're already at a declined nutritional status with no nutritional interventions so far, they need some advice. So essentially, that food intake would give about 350 kilocalories and about 5 grams of protein. And that's good for a lot of our surgical population in the hospital. What if a patient cannot eat? My area of interest has always been around early enteral feeding, and this is certainly what I did my PhD in. And the reason for that is obviously early enteral feeding is associated with protection of the gut-associated lymphoid tissue to prevent villus blunting, and also, and this is very early work, around gut permeability. So it's really important to try and improve, obviously, oral intake on day 1, but it's the quality of the nutrition as well. There are many guidelines out there, and with most guidelines, more studies needed, more studies needed, more studies needed. And I would really urge PQIP to actually look at what nutritional information you are capturing, because the volume of patients coming through PQIP could really give some quick wins in terms of the implications of poor nutritional status and perioperative recovery and outcome. This is all very well and good, but how do you actually change practice? I've spent my career to date trying to do this, and it's very, very hard. And we've just recently finished our prehabilitation and optimization program, which was in lung cancer, and early results suggest that we can actually promote patients to put on muscle mass, put on weight, and reduce their fatigue in the lead-up time to patients undergoing lung cancer treatment with multimodal prehabilitation. So that's nutrition, psychological support, and physical activity and exercise. I think this is the age-old question. Do we actually delay surgery for optimization in terms of nutrition and or prehab? And I think, I'm very excited to see how that direction of travel goes, certainly in the UK. And, one thing I would say is, do you actually need to delay surgery if the patient started their optimization at the initial entry into the primary care setting? Just a thought. We published a study called Fit for Cancer Treatment, which essentially used optimization in primary care to start that process. We used an optimization bundle, which actually covers a lot of the things that were discussed in the session earlier, such as review of existing comorbidities, screening for new morbidity, anemia, smoking, lifestyle events, as we've just heard, but also HbA1c and nutrition are in there. And we are, as I say, on the cusp of widespread implementation of this within Cardiff. This is what our current plans look like, and it's actually joining up all the individual pieces of work that we've done over the last sort of 10 years. And essentially, patient presents to the GP then signs post to an optimization team, and performs the optimization bundle, whilst the patient's going through the diagnostic process. Prehab will be initiated when the patient has a highly likely cancer. And you can see that nutrition is underpinned throughout the whole cancer pathway. So to summarize, you must provide sufficient protein, 1.2 to 2 grams, and that should be really under the instruction of a qualified dietitian. You need to give enough energy to obviously meet calorific demands and also protect the protein, otherwise you'll be degrading your protein for energy. Underpinning that with adequate micronutrients and obviously antioxidants, all that under the umbrella of optimized homeostasis. And clearly, as anaesthetists and perioperative teams, you will be the absolute experts on that. And fluid management, as I heard this morning, which is really, really important. Omega-3s as well, the jury's out, there's lots of emerging evidence around that, and vitamin D and calcium supplementation. I think for a long time, people have paid lip service to nutrition, and I'm really pleased that Ramley's asked me to speak today. And I think we have to move into a conversation and reignite this area. And I really appreciate, obviously, the teachable moment in terms of using this as not just an opportunity to detect malnutrition and treat malnutrition, but also in terms of the public health messaging overall. Thank you very much.